My name is Jose Baselga from Barcelona. I am one of the co-chairs of this plenary fourth session. And we're going to start the second and last part of today's program. We have one presentation that I'll go over, some of the new data on PI3 kinase inhibitors. And then after my talk, we will have discussion about academia and industry relationship. It's going to be a panel discussion that I would hope you will enjoy. So what I'd like to do now is to continue with the program that is covering new and exciting targets. And the topic that I will cover is the PI3 kinase pathway as a target in breast cancer. Now, this pathway and this target has been proposed as quite important for a number of years, but it has been also quite new for clinicians, for all of us who have been dealing with therapy. So what I'd like to do today is present a little bit of the concept of this pathway, its role, what it does, then go on and review the data on PI3 kinase and breast cancer, how frequently PI3 kinase is aberrant in breast cancer, and what are the potential clinical implications of this. And then, at the final part of my talk, I'm going to review what are the potential strategies that we have today to target the PI3 kinase pathway, and we will review data on mTOR inhibitors. We will talk about some of the feedback loops that appear to be present when you block these pathways. And then finally, we will go over some of the data with some of the new and exciting PI3 kinase inhibitors. Now, you have seen several variations of this pathway description. You can gather and see the complexity. But this one is PI3 kinase centric. As you can see, the PI3 kinase is very close to the receptor tyrosine kinases. The PI3 kinase has two components, has an inhibitory component called P85, and then it has a catalytic subunit, which is the P13. And this enzyme gets activated whenever ligand binds to receptor tyrosine kinase, then either directly or via mediator proteins such as IRS1, the P85 inhibitory activity is lost, and then P13 alpha has the capacity to convert PIP2 into PIP3. PIP3, which is a lipid that is in the membrane, then activates or allows the activation of AKT, a very important element in the signal transmission pathways of receptors, and that leads to an activation of important pathways that control a number of important protein cellular functions, such as protein synthesis, such as cell survival, such as cell cycle progression, and such as metabolism. And you'll see some of these very important mediators, such as mTOR, such as P53, such as FOXO, etc. So I cannot think of a more important pathway, perhaps, in cancer metabolism and growth. And as George here then mentioned on the first day, the PI3 kinase pathway is probably one of the most important hubs that is present in cancer. And we have indirect evidence that this pathway is important by looking at how frequently this pathway is aberrantly hyperactivated in cancer. I hope you can see the little stars here, and each star represents two places where activating mutations or deletions have been identified. Now, in addition to the activating components of the pathway, I'd also like to remind that some of the components of the pathway have an inhibitory effect, such as PTEN, that you can see here. So a PTEN loss activates the pathway because PTEN has in charge the reconversion of PIP3 into PIP2. So that's an important element that I wanted to explain. And as you can see, we have mutations at the level of receptor tyrosine kinase receptors. We have mutations at the level of PTEN itself, at the level of AKT, PTEN deletions and mutations, DRAS, etc. And how frequent are these mutations in several tumor types? Well, it depends, but in the case of breast cancer, they are quite frequent. As you can see, PI3 kinase mutations occur, depending, but in about up to a quarter of breast cancers. It's more in some subtypes. We will see this in a moment. We have also PTEN abnormalities in up to 1/3 of tumors. And overall, I would say that if we look at phospho-AKT, that is AKT that is activated as a surrogate marker of the pathway being activated, in about 40% of breast tumors, you have indications that this pathway is aberrantly activated. So this is not a small number. This is a pathway that has an importance in a significant proportion of breast tumors. Then this pathway also is turned on or activated in a variety of other tumor types, and you have some of the examples here. So glioblastoma multiforme being an example, colon cancer, lung cancer, etc. Now, when it comes to PI3 kinase, there are a variety of mutations, but we know that there are hotspot mutations, and these are the most frequent ones that occur at two sites. We have mutations at what we call the kinase domain, and this is the one that is in the bottom. And then we have mutations also in the helical domain. And now we are beginning to learn that these mutations that occur in different frequency may not have the same phenotype. So the pathways that they regulate and the feedback loops that might be involved are going to be slightly different if you have helical kinase mutations and if we have mutations at the kinase domain. So I think this is something that even in the clinical trials, we are beginning to analyze carefully. And how frequent are these mutations in breast cancer? So overall, the proportion of mutations in breast tumors is about 20%, 20 to 25% if you take all the samples. But what we are beginning to see, and this is data from MD Anderson, that they look at their series of patients that they had the capacity to analyze for PI3 kinase, that the proportion of mutation varies depending on the different tumor types. So for example, in hormone receptor positive tumors, the mutations occur in over 30% of cases. And also in HER2 positive disease, the mutations are in about a quarter. And it seems that the mutations in triple negative may be less frequent. Now, this is not written in stone, and as more series are being gathered, these numbers could change. But I think this has given us at least an initial picture on the distribution of these mutations in the different subtypes of breast cancer. And also you have on the right the description of PTEN alterations as well, which are there, although maybe less frequent. Now, we have been used to interpret that mutations in oncogenes result in a worse outcome. And I think mutations or amplifications, and I think that the classical example in breast cancer has been HER2 overexpression that, if untreated, has clearly a much more aggressive course than non-HER2 amplified breast cancer. And people are beginning to look at what's happening with PI3 kinase. And the surprise is that maybe PI3 kinase mutations do not confer necessarily a worse outcome. This is data from the breast group at Memorial Sloan Kettering Cancer Center that they published about 6 months ago in Clinical Cancer Research. They had a beautiful data set of patients with node-negative disease over the years, and they were following the cases clinically, so they have complete clinical follow-up, and they looked and what was the implication of having a PI3 kinase mutation on clinical outcome. And surprisingly, at least surprisingly to me initially, is that PI3 kinase mutations, if any, confer a better outcome. So in these graphs, where you look at progression-free survival and survival, the mutant tumors are those displayed in the blue line, so they seem to be doing better. So we have to be careful when we analyze the clinical data with PI3 kinase inhibitors or with mTOR inhibitors, if we are going to compare this with historical samples, because these tumors could have a better outcome. The corollary of this, though, is that maybe if we inhibit this pathway in these tumors that are dependent on PI3 kinase, we could get superb results, and perhaps we can conceive a possibility that we might not need chemotherapy in these patients because they could have, to begin with, a good prognosis, and with a non-toxic regimen, maybe these tumors could be treated appropriately. And some of the ideas that you'll see at the end of my talk reflect this approach. Now, we also are beginning to learn that PI3 kinase mutations may play a role in resistance to some of the therapies that are blocking upstream receptors. Since we are in France, I could not resist the analogy, and I think in the case of HER2 resistance, in a similar fashion as Jules Verne wrote this beautiful book of A Voyage to the Center of the Earth, I think that in the case of HER2 resistance, if we want to find some of the mechanisms, perhaps we have to initiate a voyage to the center of the cell. And that's the, if it works, that's the proposition here. And in the center of the cell, what we have is the PI3 kinase pathway. And now we have data that support this. So work done at the NKI in Amsterdam by the group of René Bernards, in collaboration with the group at MD Anderson by Brian Hennessy and Gordon Mills. What they did is that they look at PTEN status and PI3 kinase mutation status in patients that had been treated with trastuzumab. And on your left, you have the summary Kaplan-Meier data showing that tumors that have PTEN deletion or PI3 kinase mutations do respond less to trastuzumab. So clearly, that's a mechanism of resistance to trastuzumab in HER2-positive breast cancer. And that's quite logical, actually, because trastuzumab, what it does is blocks upstream from PI3 kinase. So if you have a downstream mutation, probably it is logical to see that this would overcome the upstream inhibition. Now, at the same time, a postdoc in my lab was looking, using shRNA libraries, was looking at potential mediators of resistance to lapatinib. And doing these screens, PTEN would come up every single time as a major player in lapatinib resistance. So I think this brings everything together, and again, it makes a lot of sense. So PI3 kinase and PTEN could mediate resistance to anti-HER2 therapies. And this is to show some examples on how we see this in plates. So in this experiment showed here, T means trastuzumab, L means lapatinib, T plus L means the combination with both. And you have cells with different levels of PTEN and PI3 kinase expression. So you have control cells with wild-type PTEN and wild-type PI3 kinase, cells with PTEN deletion, and then in the bottom, you have cells with P13 alpha overexpression or cells with PI3 kinase mutations, the two of the most frequent ones. And as you can see, by the amount of cells that is shown by the blue color, these cells that have mutations are clearly resistant to both trastuzumab and lapatinib. Does it happen the same with estrogen receptor therapies? Probably yes. And we have now emerging data that, and we are identifying what are potential mechanisms of resistance to anti-estrogen therapy. And some of the data is well known. So we know that HER1 and HER2 could mediate resistance to anti-estrogen therapy. We also know that the insulin-like growth factor receptor is a mediator. But as I said, we have now emerging data that PI3 kinase mutations and mTOR also could mediate resistance. And the good news about this is that we can intervene at every single one of these levels. And that's going to be perhaps one of the most exciting areas in the therapy of ER-positive disease, how to incorporate these biological agents that could revert resistance. So this pathway is important. This pathway is aberrant. Can we intervene? And as I showed in the prior slide and in this one in a more comprehensive manner, we have multiple opportunities for intervention. And in the clinic today, in addition to the monoclonal antibodies and the tyrosine kinase inhibitors against the receptors, we have PI3 kinase inhibitors, we have AKT inhibitors, and we have rapalogs, which are rapamycin analogs, and pure enzymatic mTOR inhibitors. So this is what we are working. Now, the first ones that came to the clinic were the rapamycin analogs. And the way they work is that they interfere with mTOR1 complexes, which is the complex by mTOR and RAPTOR. And we have now clinical data that suggests that mTOR inhibition may play a role in breast cancer. This is a neoadjuvant randomized phase 2 study that we conducted in patients with newly diagnosed breast cancer, more than 2 centimeter primary, ER-positive, and patients were randomized to letrozole plus placebo for 16 weeks versus letrozole and one of these rapamycin analogs, RAD001 or everolimus, given daily. And the primary endpoint here was response to the combination. And the study was positive. We were looking by clinical signs of response, either by physical exam or by ultrasound. So it's just a phase 2, but it was clearly an indication that this could be an interesting approach. But I think even more important, what was of telling information was what was happening at the proliferation level. As you know, Ki67 is an important marker of efficacy of anti-estrogen therapy in ER-positive breast tumor. And what you have in this slide is the data on Ki67 at day 0, at baseline. On the left, so this is a log scale. So the more you go to the left is a lower Ki67. So as you can see in baseline, in the two arms, in the placebo and in the RAD001, you had a nice distribution of Ki67 proliferation as you would expect. What's interesting is what happened at day 15. And at day 15, as you can see on the upper line, the amount of tumors that had low Ki67 was much greater in the mTOR plus letrozole arm as compared to the letrozole plus placebo. So that's a clear indication that the combination is more efficient at blocking proliferation. And based on these data, there are a number of phase 3 studies that are being conducted in the metastatic setting. Now, what happens with trastuzumab and mTOR blockade? We don't know yet. We have less data, but there is very provocative data from Fabrice André here in Paris, Gustave Roussy. In what they did is that they did a phase 1 study in patients that for most part were resistant to paclitaxel, and they all had been previously exposed to trastuzumab, and they just added RAD001. And as you can see here in this waterfall plot, the activity that they saw was quite remarkable. And that's exactly what you would expect from preclinical models. And based on this, some additional studies are also being conducted in the metastatic setting. Now, one thing that we found, though, that we had identified in the lab initially working with Neil Rosen is that if you block mTOR, you might activate some important feedback loops. And what we observed in our patients is that performing biopsies in the tumor while being on therapy, what we observed is that there was an increase in phospho-AKT. So in the top panel, you have tumor samples at baseline, and what we're looking here is at activated AKT, and in the bottom line panel, you have the same patients while on therapy. And I hope you see that there is an increase in phospho-AKT. And that was initially intriguing, but we know now why this is happening. This is the pathway under baseline conditions. And here, if you look at S6 in your bottom left, you see that there is an inhibitory pathway that blocks IRS1 signaling. And that's an important negative feedback loop. When we block with an mTOR inhibitor, this negative feedback loop gets released, and as a consequence, IRS1 becomes activated and phospho-AKT goes up. And this could prevent or could diminish the anti-tumor activity of mTOR inhibitors. You can block this by giving therapy with antibodies against IGF-1 receptor. That's one approach. And in preclinical models, we have strong evidence that combining anti-IGF-1 receptor antibodies and mTOR inhibitors is synergistic. But also, an approach that we can take, and I'll see that a little bit in a minute, is using PI3 kinase inhibitors, which are upstream from mTOR. And I think, therefore, that a second generation of inhibitors are of merit. And here is just a list of the compounds that I'm aware that are in clinical development at this time. As you can see, they are grouped by the molecular targets. So we have pure PI3 kinase inhibitors. We have compounds that block both PI3 kinase and mTOR. So these are dual inhibitors. We have pure catalytic mTOR inhibitors, and then we have inhibitors that block AKT. And the two that I'd like to discuss are the compounds from Exelixis, Sanofi, XL147, and XL765. XL147 is a selective PI3 kinase inhibitor. You have description of the inhibitory concentration 50 of the different kinases. And as you can see, this compound is a potent inhibitor of the class 1 PI3 kinase family. But it does not inhibit mTOR, and it does not inhibit the MEK pathway. So this is a pan-PI3 kinase inhibitor. It's ATP competitive, can be given orally, and it has preclinical efficacy in PI3 kinase, PTEN, and KRAS mutant xenografts. Initial phase 1 studies have shown that it is safe. We have 2 dosing schedules. We have 20 days on and 7 days off, and then we have a continuous daily schedule. We also have a cohort expansion in the first study in patients with non-small cell lung cancer and lymphoma. There's a study in non-small cell lung cancer being expanded, combining XL147 with erlotinib, and there is also a study XL147-03 that is combining it with paclitaxel and with carboplatin, with cohort expansions in endometrial, ovarian, and non-small cell lung cancer. 48 patients enrolled by the time this was presented this year at ASCO by George Shapiro. The MTD has been set for the 21/7 schedule, still going on the continuous. The toxicity appears to be rash. For most part, this compound is well tolerated. We have excellent pharmacodynamic evidence of inhibition in the pathway in patients, and we also have evidence of clinical activity in these early days. So we have responses in non-small cell lung cancer, and also a proportion of patients that have long stable disease for more than 12 weeks, and this is about a third of our patients. And these are beautiful pharmacodynamic data in tumors. And I hope you can appreciate this well from the distance. So here what we are doing is that we are looking at AKT that is downstream from PI3 kinase and phospho-ADP1 And as you can see, there's a major inhibition. And we have seen this in multiple tumors, as you have seen here. We have seen this in tumors that have PI3 kinase mutations. We have seen this in tumors that don't have PI3 kinase mutations. So it's happening across the board. So we are satisfied and we are convinced that we are hitting the pathway substantially. And something interesting here is that this compound inhibits also ERK signaling as seen by immunohistochemistry. We see this in the lab, we see this in patients, and that's a unique feature of these exelixis compounds. We don't see this with mTOR inhibitors. Actually, we have published the opposite, that there is an activation of the phospho-ERK pathway, and we don't see this with the other PI3 kinase inhibitors either. And we're working on the mechanisms, but we believe that probably have to do with regulatory pathways. Now, moving to the other compound, XL765, that's a dual mTOR PI3 kinase inhibitor. It's a catalytic inhibitor of TORC1 and TORC2. So a broader anti-target spectrum, if you will. And again, oral and has preclinical efficacy in a variety of models, regardless of PI3 kinase, PTEN, and RAS status. There are a number of clinical trials in phase 1. The 001 study with looking at different dosing schedules, daily or twice a day. We have studies in combination with temozolomide in glioblastoma multiforme, and then studies in combination with lapatinib with expansions in non-small cell lung cancer. 51 patients enrolled at the time of the last report at ASCO this year. We have an MTD for the BID schedule and still enrolling on the daily schedule. The DLTs here were transaminase elevations. They were reversible and not seen at lower levels. And also excellent pharmacodynamic activity in normal and in tumor tissue, and some evidence of clinical activity as well, including patients with KRAS mutant colorectal cancer. And this is the same as we had seen before, impressive inhibitory of the pathway by looking in tumors and looking at phospho-AKT and looking also at phospho-4-EVP1. And regarding the question on ERK, is the same story. So we also block in these tumors ERK pathway activation, and that's a unique feature of this class of compounds. So with this data, we are moving into the phase 2 setting, and we have two strategies. We have a strategy in ER/PR positive disease, and we have a strategy in HER2 positive disease. So two studies that are either open or about to be opened. We initially are going to be taking all comers, but we're going to have archival tissue on everybody, and if we can, we're going to collect fresh tissue, and we are incorporating real-time PI3 kinase and PTEN deficiency analysis to guide the selection, and we're going to have a number of patients on each cohort that will have a PI3 kinase mutation, so that we are sure that we have perhaps the most sensitive population. The first study is 202, and that's the phase 1/2 study of XL or 765 in combination with letrozole. That's an interesting design, because here what we are doing is that we are comparing the two agents. We all have the question on whether it's going to be better to block PI3 kinase or it's going to be better to block PI3 kinase and mTOR. We don't know. So I think this study could give us some hints. The phase 1 study is a classical one, 3+3 dose escalation, and in the phase 2 we'll have 50 subjects to accrue to each arm. And these are the key eligibility criteria: postmenopausal patients, ER/PR positive, that have recurrent and they are refractory to a non-steroidal aromatase inhibitor, measurable disease, and as I mentioned, archival tumor samples. And the objectives here, in addition to the MTD, which we don't hope to see any surprises, is to look at objective response rate and PFS at 3 months. And then the last study is in patients that have received trastuzumab and have failed. And again, a 2-arm study with 147. We have one arm, which is arm 1, in which we are comparing 147 in combination with trastuzumab, and arm 2, in which we are studying combination with trastuzumab and paclitaxel. These are important questions. The phase 1 and then the phase 2 will have 25 subjects to each arm. And the primary endpoint is the MTD with trastuzumab and with the combination of chemotherapy, and the phase 2 is to look at the objective response rate. And these are patients that have failed a trastuzumab-containing regimen, and we are going to be requesting for tumor biopsies in the phase 2 part if that's feasible. So in summary, I hope it was not too busy, all what I had to say, but in this slide we have perhaps the key messages. First one is that mutations of the PI3 kinase pathway are frequent in breast cancer, and that these mutations result in resistance to HER2 agents and possibly to hormonal agents as well. Anti-mTOR agents have clinical activity against breast cancer, but activation of feedback loops may result in decreased efficacy. The PI3 kinase inhibitors, XL147 and XL765, have been shown in phase 1 studies to be safe, to block the PI3 kinase and the ERK pathway, and they have signs of clinical activity. And phase 2 clinical trials with XL147 are underway in 2 settings, in the hormone-refractory disease and also in patients that have failed trastuzumab. With this, I'll thank you very much for your attention.